Hello, everyone. I am Graham Dodge. I'm the president of the PathCheck Foundation. We are a 501c3 nonprofit. We develop open source code and standards for public health technologies. We were founded at MIT during the pandemic in 2020 to develop privacy-preserving open frameworks and standards for exposure notifications and vaccine verification. To date, I believe our code has proliferated through various systems to where we have issued, I believe, over 2 billion vaccine credentials worldwide. And the encryption was so good, we can't even analyze those data. We have no way of knowing what's behind those data. It is completely anonymous and encrypted. So we are going to be discussing the topic of street medicine technology. So from our perspective, as a nonprofit engaged in public health technologies that was born out of a crisis, we are going from one crisis being a pandemic to what we perceive as the homelessness crisis here in the U.S. at least. And this is where PathCheck has taken a keen interest in developing tools that can help street medicine teams. So let me just provide a quick overview as to what is street medicine for those of you who aren't sure what that is. So street medicine is the practice of providing medical care to unsheltered people experiencing homelessness in locations like encampments, parks, and under bridges. The term street medicine was coined by Dr. Jim Withers of the Street Medicine Institute, which was founded in Pittsburgh, I believe, in 2008. There are over 140 cities in 27 countries that have street medicine programs now. California alone has 25 of those. So it's an especially acute crisis in California, as most of us know. Besides the actual care of individuals on the street, there's challenges in care coordination. This is where my own organization has been working with those who are on this call today and others to identify what technology solutions we can develop that provide better care coordination. And these are some of the testimonials we've gotten back or heard back through community engagement studies that the patients need coordinated care. Currently, the hospital says, "Here's your pamphlet. We wish you all the best." When another person said, "When we leave the hospital, we're not focused on our illness or injury. We're focused on where to stay, where our next meal is, how to protect ourselves from the people around us. We're in survival mode." And then others said, "We are given a list of resources, but nobody asks if we can access them. Nobody asks, are we able to make the calls? Do we have the means to get from here to there? Did I leave the hospital with my phone charged?" So that leads us into sort of the discharge process. And as a quick overview of what that could look like, when patients get discharged from a hospital or an ER, it is assumed, that they have a safe, quiet, dry, and convenient clean environment to live in, that they have beds to recover in, places to get potable water, food, ways to take their medication, places to charge their phones. And as we all know, and this is why we're here today, that's not always the case. So it's my pleasure to introduce to you our panel. Let me get back to our initial slide here. Beth Kangas from the Zumbro Valley Medical Society, Dr. Robert Hyde, also with the Zumbro, he's vice president of the Zumbro Valley Medical Society and a physician at Mayo Clinic, and Helyn Luisi-Mills, who, there she is, Helyn's here, okay, great, who most recently with Madison Street Medicine. I will now turn over to each of you. Let me stop sharing my screen. And we'll start with Dr. Robert Hyde, or Dr. Bob, as you're affectionately referred to in the street medicine world. Dr. Bob, can you please go ahead and unmute and introduce yourself to our attendees today?
Sure. Thanks very much for the introduction. Yeah, I'm Bob Hyde. I'm an emergency physician based in Rochester, Minnesota. I spend most of my time working in the emergency department clinically. And then for the last about 3 years, I've gotten increasingly involved with our local medical society, Zumbro Valley Medical Society, primarily focusing on direct care on the streets. So I'm the medical director for the Street Medicine Initiative, is what we call it here in Rochester. And it's been a privilege. It's been very educational. We're still sort of, I think, only coming up on 3 years, but still learning quite a bit about the best ways to do this work.
Thank you, Dr. Bob. Helen Mills, let's go over to you now for your introduction.
Hi, yeah, sorry I was late. Thank you for your patience. Yeah, I'm Helyn Luisi-Mills, and I am the medical programs director at Madison Street Medicine. Madison Street Medicine has been around since 2017. We did a CHNA, community health needs assessment, and discovered that the greatest need was feet. And so it started with just a bunch of medical personnel, doctors and nurses who had heard about what street medicine was. And so they started a foot care clinic once a month, and now it's grown to a program with we run a campground, which is a shelter-campground with tiny houses for people who are high vulnerability. We also have an outreach team that provides case management for housing support. And we have 4 clinics. We have 5 clinics, a foot care clinic, of course. And then we have clinic at the men's shelter, clinic at the day center for people who are houseless, and 2 outreach nights. And we have we have just 1 medical programs person, and the rest is volunteer providers, and we have about a cadre of 85 volunteers. So it's really exciting.
Excellent. Thank you, Helen. And last but not least, Beth, Kangas, and your guest Colin. Can you go ahead and introduce yourselves?
Yeah, thank you all very much. Pleasure to be here. As I'm Beth Kangas, the Executive Director of Zumbro Valley Medical Society and Director of the ZVMS Street Medicine. We, as Dr. Bob said, we started 3 years ago, and we're involved in 3 different areas. We provide direct patient care through street rounds and through community clinics. And we train the medical community, and then we advocate for changes in systems and processes that affect the healthcare of people experiencing homelessness. And then Colin, our colleague, you can introduce yourself.
Colin, I have about 3 years of life experience on the street. I try my best to give the perspective of someone who is unhoused.
Excellent. Thank you for joining us, Colin, and thank you, Beth. I'd like to start, I think, for our attendees, some of whom may have never heard of street medicine, aren't aware of the technology challenges, which is why we wanted to bring this to the surface, because we at PathCheck have a large community of volunteers, all with technology experience and background, who are accustomed to contributing to open source projects. And so we want them to understand, what are these challenges and the pain points that you're experiencing. Later, we can dive into sort of what that means from a technology perspective, but let's just start at the high level with an example from each of you in terms of, what is one story or experience that sort of best characterizes the crisis at hand and the gaps in the sort of technology, or just in healthcare in general, the challenges. What best exemplifies those challenges from your own experience, or a story from your colleagues in your environments and your communities that you can share? If one of you is ready to go ahead and jump in with an example, that would be great. I'll call him Dr. Bob then.
Sure. So there's so many stories and there's so many examples we could give. I guess what's coming to mind for me is a patient who was discharged from the hospital. Now she had a number of chronic medical conditions and sort of complex needs. And in this example, it's a little bit of the Swiss cheese model where things really lined up, unfortunately, and outcomes were, despite great intentions, outcomes were far from ideal. But In this particular instance, this patient who was unsheltered was discharged from the hospital after really an admission for shortness of breath and some related issues. And she was using oxygen at baseline for chronic obstructive pulmonary disease. So she was discharged, I think, in the late morning. And the plan was that she was going to go to our local day shelter, which I think she was able to get there, and was probably able to plug in her oxygen delivery machine at that time. But our local day shelter closes at 8 o'clock, and this person then sort of was faced with a decision: where do I go next? And I guess in the interest of time, just to sort of give you the big picture of what happened, she wound up at a local shelter that did accept her for the night, but they had a lot of difficulty. They realized the next day in terms of how are we going to manage this situation. This person had difficulty with ambulation. This person obviously needed to plug in their oxygen delivery device in order to continue to receive oxygen, which she needed. And so a number of issues came up related to, where could she sort of recuperate? Where could she live? She has this chronic need to have electricity in order to power her oxygen. And so, I think we were able to eventually come up with sort of a solution, which was multi-agency. A number of people got involved to try to figure out, how are we going to manage her transportation? Where is she going to stay? How is she going to have the additional services that she needs? And so, but, in this particular case, it just multiple issues kind of rose to the surface. And it's forced us to sort of think a little bit about our discharge planning process from the hospital when sort of there are complex needs that patients have. And that's not uncommon. Hers might have been on the more complex end, but as you alluded to in your introduction, a lot of patients do have fairly significant needs at time of discharge that those of us that are housed would just take for granted. And so it becomes much more difficult to survive and to do those basic things when you're unsheltered.
Thank you very much. Helyn, can you share a story that sort of best illustrates the challenge?
Yeah, I mean, boy, do we have stories about hospitals discharging into patients into unsheltered situations. We have a volunteer physician who works in the emergency department, and it is been multiple times at the men's shelter clinic on Monday nights that he has discharged the patient, and then we'll see them in the shelter within the time that they were recently in the ER. And we don't have medical records that he can access from his stay in the hospital. So what ends up happening is we have an electronic health record that functions more as a database because we can't afford anything else. And so trying to provide follow-up care without having access to the technology to be able to see what kind of support the client has received and what they need, and then also then the client receives care from us, and follow-up care can't see the care that they're being provided by us if they go back to another doctor, or if they see, because often we find ourselves providing sort of support care, like try to get you through to your next appointment with your PCP. But it has happened that we're just, with the technology that we have, we're not able to provide the quality of care we could if we had a stronger electronic health record.
Yes, and we'll definitely talk about EHRs and EMRs and what we can do in that specific instance to try to improve things. Beth and Colin, can you take that question next in terms of what sort of story best illustrates the challenges in street medicine and care after you leave the, hospital.
You want to-
It's tough to pick just one. I think of one gentleman who we were trying to get supplies to, who has to go in periodically to get a stint changed. And he doesn't have a cell phone, or he doesn't have a cell phone with service anyway, so we've tried on several occasions to get some of these supplies that he needs to him. But have yet to succeed in that.
And at the time that when he might be responsive, or we might see him, it's like trying to figure out the right time to reach him when he would be open to having care or even supplies. So if we had something that was more readily accessible in the moment that worked for the people that we're trying to reach, that would be a big help.
Yeah, and I know in our own discovery process at PathCheck, learning about street medicine and the different challenges, we heard a story, it might have been through you, Beth, in Zumbro Valley Medical Society, about a gentleman who had, I think it was a CT scan scheduled. Was that your story, Beth?
Yeah, MRI it was.
MRI, yeah.
Yeah.
If you don't
And
mind
then-
sharing that, because that's the one I always tell people when I start introducing, why there's these challenges and how, how can technology serve. But yeah, if you don't mind recounting that specific story, that'd be great.
Yeah, so he was scheduled for an MRI and went in for it, checked in for that, and they said, you're going to need to stay overnight, which he hadn't been aware of. And he had put his backpack of stuff behind a bush for the time of his MRI appointment. And then when he needed to secure that backpack, knowing that he now was going to have to stay much longer. But he didn't have a way to contact anybody to tell them which bush it was by, and we all could have helped with that. And then the appointment people didn't allow him to leave to go move the backpack himself. So he ended up, I believe, not having the appointment, just from not being able to store his belongings safely for a long enough a period of time.
Right. And as I recall, there was a part of the story too, where, just getting that initial appointment took weeks, if not months. Right. And so it was all of that sort of sunken time that all the effort lost at that point, and which is a real shame, obviously. And
Yeah, could I jump
yeah,
in
go
here?
ahead, Helen. Yeah, please.
Sorry, that reminded me of we had a client in the men's shelter that presented with high blood sugar in the high 300s, and he had been released from the emergency room from the hospital for problems with their blood sugar, and had been given insulin. And within the day that they had been discharged with their medication was stolen. And so, which happens all the time, we actually provide the service of holding on to certain medications so that, and then we provide a weekly amount so that people don't have to worry about getting their stuff stolen, which happens all the time for reasons such as this gentleman with the MRI. And the pharmacy would not refill the prescription for the lost medication because the insurance wouldn't cover it. This is the Medicaid insurance, without a police report. And we're talking about a population that does not have positive interactions with the police. So there was also no way of knowing who stole the medication. And this is not a population that talks about other people to the police. So he went without the insulin that he needed, and he presented at clinic, and we promptly sent him to the ER, and he was readmitted on the same day, all because he just needed some insulin that got stolen, and the pharmacy wouldn't refill it. And just the entire thing. So he just revolved right back in. There's also nowhere to store insulin because of the refrigeration needs. We see a lot of challenges with managing diabetes.
Thank you. Yeah, and certainly, if you have other thought, if someone says something that inspires you to jump in, by all means, our panelists, please jump in. We will also be opening up to questions from the attendees momentarily in about 10 minutes or so. So we have a Q&A function here in Zoom that you should be able to post questions to. And feel free to start posting questions as you come up with questions that you want the panelists to answer. But Helyn, you mentioned EHR specifically in your introduction, so I want to kind of talk about that next. I think a lot of people assume, there's Epic, there's Cerner, the EMR, EHR exists. There's a framework already there. It's easy why aren't the street, or they assume the street medicine teams are using that people experiencing homelessness have my chart or whatever that they can easily log into. So that's obviously not the case. So Helyn, can you maybe go into a little bit more detail as to exactly why isn't that the case? And what position does that then put you in to find another solution? And what drives your choice and how that solution is either created from scratch or sought after or acquired? Is it cost? Is it convenience? Certain functionality that you require? If you can kind of explain that a little bit more.
Yeah, so we're in Madison, Wisconsin. We're just down the street from the Epic headquarters. So obviously you'd think, hey, we're in Madison, you're in Madison, can we get some Epic hookup? And Epic, as most charitable clinics know, does not provide any kind of reduced or nonprofit or anything of the sort. And have no interest. And we've tried to lobby with them with Wisconsin Association of Free and Charitable Clinics. We've tried to approach it multiple ways, and they're not going to budge on that. For full transparency, the foundation wing of Epic, Roots and Wings Foundation, does provide us funding for our other programs, but it doesn't cover the electronic health record. So we do receive Epic funding through Roots and Wings, just for full transparency. So what we ended up doing is we received a grant to be able to build an electronic health record, and it was able to meet our immediate need, but it's very much like a database, and it's not searchable. It's not, you can't use any data from it. It doesn't collect any data. It's just basically a database with the patient's information on it, and you have to scroll down for dates, or you can't run any kind of report on it. So our grant funding, so we're grateful that we had that for what we had. And then we were also able to gain access to CareLink, which is an Epic product so all the clinics in the Madison area use Epic, and they have CareLink, which is where non-employees or non-providers of that facility can access the medical record. And so we applied and received access to CareLink for one of the hospitals, but we haven't been able to get them from the other one. So if the client is in that particular hospital system, then we can log into CareLink and sort of see the back end of stuff, but it's limited access to certain things, but we're not able to enter any information for providing continuum of care. And so we're in the process of working with PathCheck to figure out a long-term solution for electronic health record. And the other option that we had is an electronic health record called Practice Fusion that works with the National Association of Free and Charitable Clinics. And that through a membership fee, then Practice Fusion waives the monthly fee. But there's a lot we don't know about it because we haven't done the research. But it used to not be a very good system. But almost all the free and charitable clinics in Wisconsin use Practice Fusion because it's better than what it was and better than no option. So I don't know how good it actually is because we haven't used it, so I don't want to undermine their charitable process, but that's the reviews that we've received on it.
And we have found in speaking with other street medicine teams that they are usually designing their own to suit their needs, as it tends to be more cost efficient than licensing something else. But if Practice Fusion has something else now that's usable and affordable for those teams, then that would be awesome. Dr. Bob or Beth, do either of you have any thoughts on the sort of EMR, EHR needs of street medicine teams and why other products on the market have not been accessible or suitable?
I'll jump in. So, Mayo Clinic uses Epic, and so we have been able to leverage that a little bit in accessing medical records when they exist for patients that are unsheltered that we're caring for. And the connectivity feature of Epic is quite useful in our community because the other Olmsted Medical Center, which is the other sort of large healthcare entity in town, also is on the system. So there is, the ability to sort of share information there. A lot of the work that we do, though, is with the county, or it's with other nonprofits, and they have their own system of keeping records and keeping information, and we really have no way sort of on the spot of interfacing with that information. Not that we would necessarily want to in all cases because of privacy issues and concerns, but certainly when we're when we're trying to find somebody or we're trying to follow up on somebody's care, there isn't a way that I know of right now in real time to do that. And I think it's in some cases because of a technology barrier. And then the other thing I'll just say is that from the patient side of things, right now, I'm a patient at the Mayo Clinic. I can just pick up my phone or my iPad and I can log into my account and get my information. But I think that's much more difficult for the patients that we're serving. And as Colin alluded to, some of them don't have a phone, or the battery's not there, or maybe they need help establishing those accounts, or trying to figure out kind of how to navigate in that system can be challenging sometimes too. So that that bidirectionality that in theory exists doesn't seem to be very operational for patients that are unsheltered. And I haven't really dug into all of the barriers that exist there, but when I ask people, have you ever looked in your record? I've yet to have someone tell me they have.
Beth, any other thoughts on this topic?
Yeah, I look to Colin.
So I can't currently access the mail portal, but I have in the past. But since being on the street and changing service providers several times, I no longer know the password, so I can't. I'm sure I can call there and maybe get password reset, but.
So, Colin, for you then, and for others that is that a very typical example of just simply not being able to reset or access it because the password's gone? Is that as a result of losing a device, or is it just a matter of
their inability to charge the device at all, or even having service in the area sometimes?
I see Tomas Moran has asked a question. He's referring to Epic's or a platform called OCHIN, ochin.org, is a platform that can offer Epic at a discount. This used to be the case a decade ago. Have you checked? So is anyone familiar with this OCHIN platform, or can speak to any discounts from Epic that would, in this case with Mayo using Epic? Is that something that you're familiar with, Dr. Bob or Beth?
I'm not familiar with that. You know, our medical society is it's not a patient. It doesn't really doesn't deliver medical services. It supports others that do. So we have not. I guess we've not really been interested in developing our own electronic medical record with all of the issues that go into developing it and maintaining it. So I haven't I really haven't dug into other options.
Yeah, I look to Helyn as the Epic, the one closest literally to.
No, yeah, I haven't, I'm not familiar with it, and I will certainly be diving in to that option, just to learn more about it. Thanks for the link.
Yeah, thank you, Tomas. So let's talk about funding a little bit. So since a lot of the challenges require some amount of funding, you know, whether it's a technology challenge that requires funding to build. Maybe Beth, if you can talk about how ZVMS has worked to secure funding for implementing new technologies in street medicine, if at all.
Yeah, we are also partnering with PathCheck. So the tech side of it will yield to you all to discuss. What we like to bring forward is on the ground experience and knowledge. Sort of the ability to start with the end users and find out what's the current situation around devices and services and technology. And so we have funding for that part from United Way of Olmsted County, and for another project through the Minnesota Department of Health for that to pay people for providing that local knowledge. We've applied for another grant that we're waiting to hear from. And that's we're excited about that portion, and PathCheck, your willingness to actually build a system for the end users with the end users in mind and responding to them rather than a great technological solution that doesn't work on the ground for a variety of reasons, just like the assumptions that go into discharge planning. There are also, I'm sure, assumptions that go into the planning of technological solutions for that. So that ability to keep checking in of what does that mean for people living those situations.
And Helyn, you had mentioned receiving a grant as well, which afforded the development of your current EHR solution. Is it typical for funding to come and go in terms of elections and things like that, if it's coming from state resources or through another third party that's getting those resources from the state or from the federal government? Do you see that funding come and go, so to speak?
We are seeing a change in funding now that COVID money is run out. So there's a lot of influx of funds for services with COVID money, and that we're looking towards a future without funds like those that could really affect programming across the board in our county and in our city. The grant that we received for the EHR is a private grant, and we continue to search for grants to provide funding for the EHR for anything from like server hosting to, to buying Epic, like we'll take whatever you will give us. and we keep not getting it. And I think, like Beth, we're seeing a movement from funders to like fund client-based services and client-focused solutions. So we have funds to implement a CHNA by training and providing jobs for people with lived experience to do the CHNA. But in terms of administration and administrative things that run the organization, we're having a very difficult time finding funding for things that are like the infrastructure of street medicine.
So besides the medical record, EHR and medical record platforms and the needs that we've discussed there, what about care coordination with other partners in your communities? Can each of you speak to how that is currently done? So how do you refer someone to another program or vice versa? And that'd be for anyone to jump in on.
Yeah, I can dive in. We have 1.5 time staff nurses, Pam and Joanna, and they, Joanna in particular, provides a lot of follow-up care for clients. So she's connected with a couple of the hospital systems to engage in supporting discharge from the ER so that people are providing continuing care. Our medical director has provided some inroads in making relationships for that discharge process so that we don't have the situation like what Dr. Rob shared. She also meets with clients, gets them to doctor appointments, gets them to get, we have the medication that we hold on for people and provide it. So she does a lot of continuing care. She does wound care. She saved someone's foot in the time that I've been with Madison Street Medicine, which is amazing because the hospital was ready to amputate and the client was like, I don't want my foot amputated. And she's like, if you're willing to do the work, let's see if we can do that. And together they saved his foot. It's phenomenal commitment from her. And then there's also other street outreach. So the city and the county has a coordinated continuum of care as required by HUD. And so through the continuum of care, we have regular meetings with other outreach organizations that do street outreach. And so they reach out to us for if they come across people with medical needs, we reach out to them. If we come across people who have needs that they provide, one of the organizations just hired a psychiatrist. So our nurse is able to provide referrals, like do intake and referrals for psychiatric treatment from this doctor, which is really exciting. So we're able to see finally some intervention for mental health support through the referrals. So, but the continuum of care is pretty good. It's a weekly meeting of all the outreach providers.
So yeah, I mean, besides the ability to do something like save a foot, right, from amputation. I mean, that's going to save a lot of cost, a lot of time, a lot of anguish. I from what I understand, there's also the realization of readmissions and the cost of penalties that the hospitals may receive if a homeless patient continuously is entering, let's say, the ER with the same condition, and because presumably they're not getting the help that they need outside the ER, or there isn't a proper handoff, so that there is that financial incentive for the healthcare systems to also ensure that there's care coordination outside the four walls of the hospital, which impacts penalties levied by Centers for Medicaid and Medicare Services too. on those hospitals for those readmissions. And now we hear about the incentives for other social workers, community care workers to be reimbursed for serving the homeless in street medicine. Can any of you speak to maybe that topic as well, or continuing on the same topic of care coordination, but just kind of thinking through where are these incentives or penalties and how are those driving care coordination outside the four walls of the healthcare system?
I'll turn to Dr. Bob to start with that, and then I can talk about coordinating with other agencies.
Sure. So in terms of care coordination, at least in our community, there's, I would say there's a pretty robust care coordination system in place. And as I said before, it's interagency. So the hospital does quite a bit of, they connect quite a bit with county social workers. The clinic also has some outpatient outreach that, and I don't know the full scope of their services, but they're certainly involved as appropriate. Increasingly, we've been using our community paramedics for follow-up purposes and to help with care coordination. And one of our community paramedics actually just recently accepted a job at our day shelter and is now kind of running their medical clinic there. So it's I kind of think of it as a spider web. It's like this kind of a rich network of wires that intersect. Sometimes I think of Dr. Kangas as being at the middle of that spider web because she kind of knows who to call when, and has increasingly kind of become that person that you're not sure who's providing the service. Why don't we call Dr. Kangas and kind of find out, and then she knows which spindle of the web to send you down. But it is challenging, and I still don't have a full grasp of all of the services and all of the different agencies that are doing specific types of work. Our county does maintain something called the Green Book, which is this printed pamphlet on green paper, which we distribute freely to everybody in the community. But it does list services, and I think is often helpful for people that are trying to find specific services. But this is a huge part of street medicine, is being able to figure out, okay, this person has this need. I can't deliver that service, on the street. Either I don't have the expertise, the equipment, I'm not the right person to do it by training, whatever the case may be. And so connecting them with the appropriate agency then becomes the next, in our mind, the next important step. So how about I pass it over to you from here?
Yeah, thank you. So definitely, if we do have the resources here, I think, and the willingness to work with each other, the agencies. But in the case of the person with the oxygen tanks that needed to move, and she had suitcases as well, so she had to haul her suitcases plus her oxygen tanks from the day center to the overnight shelter back again. We were trying to coordinate that through phone calls, texting, emails, which is very time consuming and very isolated, right? So if Dr. Hyde and I were texting, and then somebody from the day shelter was calling, somebody from the county's housing stability team was phone calling or emailing with the overnight shelter, very time consuming. And what we find too is we do weekly foot soaks at an overnight shelter. There might be an issue that comes up in our 7 to 9 p.m. window. And then how can we do a warm handoff the next day when people are back in the offices? So some way of coordinating, doing this care coordination with technology that keeps an active centralized record of all this correspondence that we were trying to do, plus account for people's work schedules and when we might meet somebody or when somebody might have a need. and want to be able to start care coordination, but then how do you reach people with everybody's different schedules?
And we have a question here from Janet Murphy. She says, if street medicine programs are part of a healthcare system like Mayo or UW Health, do the street medicine programs have access to an EHR? And what are the barriers to healthcare systems integrating with street medicine? So we've kind of touched on that a little bit already. We know that Mayo does use an EHR with Epic. But any other comments on this question in terms of the integration and the flow of the medical record kind of serving the patient outside the four walls versus integrating the street medicine program sort of in-house in some ways, or challenges in doing that would prevent you from leveraging those systems in that way?
I just got back from a national meeting on healthcare for the homeless, and there are many street medicine programs that are integrated into their health system. And I think all the systems are different and they have different ways of doing it, but that is certainly an advantage, I think, if a street medicine team kind of has that connection, has an easy way to refer, has an easy way to get testing. Not that it's easy to get testing or to get someone to a referral, but at least to have the option to set it up electronically, and facilitate some of those things. My kind of hope for us in Rochester is that we will fully integrate with the health system, with one of them, because I think it really would facilitate the care that we're trying to deliver on the street. And it would most likely bring more resources to the street as well. Where we're relying on grant funding and a lot of volunteerism, I have concerns that may not be a sustainable model. But in other parts of the country where there is better alignment and again, like incorporation, like you're talking about, into the medical system, I think that's probably where we have our best chances for success. So at least in Rochester, we're building the plane as we're flying it, or we're flying the plane as we're building it. I don't know the right expression there. And we just didn't want to, at least I just didn't want to wait till all the pieces were together to get started, because there's a real need happening right this minute. But I'm hoping that's the direction we're going to move in our community.
We would love to.
Yeah, go ahead,
Sorry.
Helyn, sorry.
Oh, we would love to be integrated into any of the health systems in Madison. But we've been denied that. So the most that we've been allowed to access is one system's CareLink. We are in the process of getting approved for another system's CareLink, which is that access to the back end, to just being able to see the record, but not be able to add anything to the record through Epic. We've approached with data, all the hospital systems. We have 3 in Madison. Well, technically 2, but 3 in Madison. And they're just not seeing the big picture on it, unfortunately. In terms of funding, like they don't provide any funding at all for any of our programs. I think we got $1,000 from one of the foundations once for like a cute little thing. But there's a respite care shelter for families with children. They don't provide any funding for that. So they literally call that shelter to discharge someone to that shelter, but they don't provide any funding for that shelter. So it's we haven't found the right person to ask, the right connection to make, the perfect report or data to sort of get that relationship going. There is a lot of coordination with discharge social workers and outreach staff and our outreach staff. So at least there is some conversation. So we do get calls and say, so-and-so is being released from the ER tonight. Is there anything you can do? So they know we exist, but there's no integration, unfortunately.
So I was just reading a statistic that, according to Hyde, on a single night in 2023, roughly 653,100 people in the US experienced homelessness, up by 12% from the year before. And I know from our own discovery process at PathCheck and speaking with other teams in California where the crisis is a lot more acute, that when you talk about street medicine, things change at scales, right? At the scale that you may be, and the challenges that you experience in Madison and in Rochester, Minnesota, that there seems to be a profound change in what the infrastructure or lack thereof means for street medicine in a population like California, where, in Los Angeles or San Francisco, they are experiencing just record numbers of homelessness there. What is the infrastructure? So what can we all do as concerned technologists in developing the infrastructure that allows, or that, well, not allows, but allows there to be a way to mitigate these challenges in care coordination and street medicine at scale that can be developed now in communities where, maybe thefts of smartphones or the lack thereof of a smartphone isn't as pronounced in certain communities. But I know when talking to teams in Los Angeles, it's a lot more rampant, and there's a lot less people that are able to utilize services via the smartphone. So is it a matter of, for example, making sure anyone who's experiencing homelessness has a device, has access to chargers, all that kind of stuff? What other infrastructure needs do you think there are when you start talking about scale and you start thinking about what you're each dealing with in your own communities versus what a community in Los Angeles may be dealing with?
I'm very curious but anxious about what the Supreme Court ruling will be in regards to people who are unsheltered and criminalizing homelessness, because I think that will significantly affect how policy is written and carried out moving forward. This is a Supreme Court decision that we're waiting on regarding sanctioned campgrounds and whether or not it's criminal to stay in a park if the city has no other place for that person to stay. Is it cruel and unusual punishment? And so waiting to hear on that. So in the meantime, a lot can change after that ruling comes. But in Madison, I think somewhere between 15 and 20,000 units short of housing, of affordable housing in the city. So, and that's like workforce housing, so teachers and government employees. There's a lot of funding for people who are houseless who have children. So there's a lot of movement in our, community in regards to like no child should be sleeping on the street, right? No child should be doubled up on a sofa. So there's a lot of that, but we have several hundred people who are without children, who there is just not enough money for permanent supportive housing, for Section 8 vouchers, for Section 42 housing. So for any kind of housing that is available. So having an infrastructure that looks towards housing is really important, because otherwise we're just building another day shelter, we're just building another night shelter, we're just building more shelter and not addressing the infrastructure of what's challenging. So a previous administration in Madison did a lot to criminalize homelessness. So if you sat on a bench for too long, you get a ticket. If you sat on a set of steps for too long, they installed a bunch of ATMs so that there couldn't be any panhandling in certain areas because the code was you have to be a certain amount of feet away from an ATM to panhandle. So they just installed a bunch of ATMs everywhere. So a lot of criminalization of homelessness. And now the new administration has undone a lot of that. So this new administration has provided more funding for the sanctioned campground, for example. So when COVID was happening and they said that you couldn't move people off encampments, and then now that it's over, the city did fund a sanctioned encampment with the tiny homes. So the infrastructure of actually supporting housing is important because the rest of it is just propping up services.
Thank you. Yeah, and in terms of your own communities, I imagine if the national rates are increasing, then you're seeing increases in your own communities of homelessness. And so then, yeah, I guess another way of also phrasing this question would be, what concerns you in your own communities there, then, and so criminalization is a great example in terms of how do you kind of change the way things are doing now so that as things grow and scale, they're not creating more problems, and that the problems aren't growing exponentially, or the infrastructure is able to withstand or handle that increase in homelessness. And we only have a couple minutes left, so Dr. Bob or Beth, if either of you want to kind of jump in on this with sort of a final, in the context of sort of final thoughts on this challenge of scale and infrastructure in your own
Yeah, so
communities.
just one thing, as you're talking, Graham, I'm thinking if I had a really good answer, I would have told you a long time ago. But one thing that kind of comes to mind now is, one thing we don't have is like a dashboard, right? We spend so much time trying to figure out where can this person go, or there's a housing list, but frankly, we just tell people, well, we'll wait, we'll call you when something opens up. There isn't like that, like, well, what's going on in the community right like now? Is there a bed over at this shelter, or is it full? Or what's happening with referrals in ophthalmology? Is it going to take me 3 months to get in, and I have to think about going somewhere else? So you know I can navigate the system. Like I have the patience, I can do it. I have the technology at home, but that's not so easy, I think, for a lot of the patients that we're serving. But when I think about all the hours that goes into care coordination and trying to figure out, how to get somebody a service that's somewhere in the community that's not affiliated with my organization, there's a ton of time that we put into that. So I don't know, that's maybe one idea of how to leverage, like you said, on a larger scale, especially as the need goes up and the number of service organizations increase. It would be nice if we could look at it and say, here's what's available right now. And when I come back to it in 2 hours or 2 days, I can see how it's changed.
And that dashboard, in your opinion, is that something that then integrates both with EMR, EHR systems, and care coordination tools?
Yeah, I mean, because the medical care is like such a small piece of what we do on street medicine. I mean, obviously, when somebody has an acute issue, we go after it. That's and that's what I do. I'm very comfortable with that. But it seems to be, at least in my experience so far, just a small piece of the puzzle. And those other things that you're referring to is really, and as some, I think, as Helyn said, like housing is basically healthcare. So if we could get more housing, we could really kind of get I think, at a lot of this problem. It's not that people have an infection on their leg that is, I mean, they do have those and they do need to have those treated, but why do they have it in the first place? It's because they don't have housing. So yeah, I think the more integration along those lines, thinking about what is all the things that this person needs, could be very helpful and beneficial.
I think housing is healthcare is the pull quote from today.
Okay.
So Beth, Colin, Helyn, any just in like 30 seconds or less, any kind of final thoughts?
Like Dr. Bob was saying, if if we had a great answer, we would have said it already, but yeah, I appreciate everyone and all their hard work and trying to come up with some sort of solution.
Yeah, definitely housing would be huge. So any effort towards that and not criminalize the situation further. So it's really the bigger systems that we need to work on while working on the integration and care coordination.
Excellent.
Yeah, something that comes to mind is what our colleague Butch says. He lived on the streets for a long time, is our health outreach advocate, and he always ends meetings with, "It's houseless, not homeless." People's home is where they want it to be, so it's a very different paradigm. So it's houseless, not homeless.
Well, and thank you all for sharing your insights on this paradigm that so many people still fortunately aren't familiar with, but also need to learn about so that we can make this all better experience for everyone involved and try our best as a society to prevent homelessness in the first place, but then find the right ways of serving the houseless, forgive me, when that does occur. So thank you all for your time today and joining us at the PathCheck Foundation webinar series. And thank you all for attending and asking your questions. And we will be posting this to YouTube soon after we conclude. So thank you all very much. Take
Thank
care.
you.
Bye-bye.